And this is very important, how long-term control blood pressure. Because you really, if you are depending on a patient who's has a busy life or cannot really follow a medication properly, then you're not going to have a long-term blood pressure control. We need to think of establishing the structured evidence-based hypertension interventional program, and we need to focus on that because building an RDN or renal denervation or what we call evidence-based hypertension intervention program is really a very important step. What are the things that we need to think of? I mean, selection of patients. Now, the strongest indication that we all agree upon, and we all voted on this when it comes to the consensus, that resistant hypertension is a clear indication for renal denervation. And we strongly recommend that all resistant hypertension patients should be considered and referred to a renal denervation program. What's the resistant hypertension? Systolic blood pressure more than 140, over 90, on three or more medications, including diuretics. How many of our patients are there in our clinic every day that they have 3 medications, 2 plus diuretics, and their blood pressure is higher than 140? There is a lot, but we need to confirm that with ambulatory blood pressure. That's the recommendations. Or if you don't have ambulatory blood pressure and the patient does not like it, you can use the 7 days of blood pressure monitoring at home, where you write the guidelines for the patient. You say you need to sit for 10 minutes, doing in a sitting position, teach him how to do the blood pressure reading, wrap the cuff with the level of the cuff, relax for 10 minutes, and do it from the same arm and away from the last meal 2 hours. So you give him a written paper, and this is where the coordinator is important, and your nurse. Give him a written paper of all the instructions. Give him the paper to write the blood pressure. Do an already established paper for the patient. So they do the 7 days. And then I have an Excel sheet. I made an Excel sheet. I say to my patient, I'm going to text it to you on the WhatsApp. So he will put his blood pressure, and I will actually take the average. And it gives me the average at the end of this. So I don't really do any math or any calculations. So if you want, I can share it with you. Assess adherence to medication. How do you assess adherence to medication? It's very important. There are multiple ways of assessing adherence. You can do bill counting. You can actually have a family member with the patient if they are old. And you really have to go through what they do. And I don't let patients say, well, I take my medication. I said, okay, where is your medication? Bring your bag. So they bring their bag. They put it in front of me. I say, what time you take this one? And how many tablets of these? So I really go through a very adherent and a very meticulous count of medications, because this is important. You really want to know what's really going on. Ideal candidate for renal denervation is, of course, is the resistant hypertension. Intolerant to medications. I mean, there are people who doesn't like beta blocker, males with sexual dysfunction, side effect to diuretics, hyponatremia, dizziness, itchiness, a lot of side effects to diuretics, and a lot of people doesn't really like it. If the patient have a sort of renal dysfunction, although this is going to be an interesting field to study this more, but now the cut point is some say 30. We adopted on the GIS the 40. Suitable renal artery anatomy, and that comes by doing proper imaging. And of course, the persistent high blood pressure after you make sure that they are adherent to therapy. You need to exclude secondary causes. So renal artery stenosis, they should not have renal denervation. Primary aldosteronism, renal parenchymal disease till now. Obstructive sleep apnea. So patient who comes, you have to ask about snoring, about apnea at night. You have to maybe possible refer them to a sleep clinic and do a sleep study before you actually expose them to the procedures. And of course, working up the renin and all the other endocrine causes with your endocrinologist. The renal artery anatomy, the suitable one or the ideal one is a diameter more than 4 millimeter, a length more than 20 or equal 20, no significant stenosis, and of course, no previous renal artery intervention. The contraindications, we don't do it in pregnant ladies, of course. We don't do it for people who are less than 30 ml of creatinine clearance, GFR, the people with coagulopathies or renal artery abnormalities. We need to do a proper renal artery imaging, whatever your center is experienced with, a CTA or MRA, but you need really to have a proper imaging, especially at the beginning. As you get more familiar with the procedure, you may actually say, well, I'm going to actually just do a selective imaging, but remember, 25% have an accessory renal artery you may miss if you don't really do a proper imaging. Baseline lab, which include all the creatinine functions, all the coagulopathies, and of course renin, and the metanephrines, all these before you do it. You do the office blood pressure readings, and you do the home readings. You optimize medication. And interestingly, you need to have multidisciplinary evaluation. What we talked about, we talk about creating a team within your institution where you are the interventionist or whoever you are, your vascular intervention, who can lead the program. You need a hypertension specialist, you need a cardiologist, you need a nephrologist, you need an internist, or an internist. You need a nursing staff who was trained in hypertension management, educated, and of course they have a cath lab protocol established for the renal denervation. You need to have discuss the anesthesia. You don't want any surprises, all right? Although with the RECORE system currently, anesthesia is not the issue. Program coordinator for case intake, of course, scheduling and follow-up. You need a pharmacist who actually can do a proper counseling and recounseling and optimization of therapy. And always, a man without data is a man with an opinion. So if you don't have your data and you don't collect and you don't write it down and you don't really follow them up and register it and you have a KPIs, then nobody believe you, and you cannot move forward. This is the GIS protocol that we just showed in our GIS consensus. This will be after publication distributed to all clinics to follow in the future. We need to do the comprehensive evaluation of the renal artery, blood test, education, and of course the team. The post care, which is very important, we need to have 2 to 6 hours observation or maybe an overnight. It depends on your center, but it's a femoral puncture till now. So you need to be careful not to discharge patient unless you have a good closure device. You can't discharge patient within 6 hours. Renal function assessment within 72 hours. Discharge with a blood pressure monitoring plan. You give them the table and you ask them to come back. Patient instruction to avoid activities for 72 hours. You need to see them in 1 week, 1 month, 3 months, 6 months, and after that you do them on an annual basis. And each you have to set up the target. Once you build the program, you can follow them up. Of course, you have always to establish your referral program, and I'll talk about it tomorrow, and of all your KPIs. When it comes to the guidelines, which is the second part that I was given the task to talk about, this is the easiest part. Guidelines are very clear. It's written by the American Heart, it's written by the European Society of Cardiology and the European Society of Hypertension. They all recommend renal denervation with minor differences between the three. Mainly, it's an adjunct option for resistant or uncontrolled hypertension. Patient with the stage 2, this is 2B when it comes to the HA. 2B for the European Society and 2 for the European Society of Hypertension. All says that once you have uncontrolled hypertension, then you should consider patient for renal denervation. The addition that is actually in recent guidelines in 2024, that they add people with high cardiovascular risk to be included on the renal denervation recommendation as a 2B. So this is from the AHA, ACC hypertension guidelines. I will stop here and leave for the next speaker to show us the first experience of our renal denervation. Thank you.